All right. Good morning, everyone. My name is Lucas Sater. As my day job, I'm a Senior Director of Reimbursement at the University of Maryland Medical System here in Maryland. But I'm also the Region 4 Webinar Chair for the Maryland HFMA chapter. And today I'm very excited to host a presentation on the 2024 CPT coding and regulatory updates. But first, before we get started, just a couple of administrative items. As I did just mention, this presentation will be recorded, is being recorded, and will be shared and available after the fact. We should be sending out, if we haven't already, a PDF version of the presentation. I think there has been a couple small changes made, so we'll be sending a new version of the presentation out after the fact as well, so everyone will have the most up-to-date version. We're going to have three polling questions throughout the course of this presentation. We do have CPEs available for those who answer all three polling questions. If you want to qualify for the CPE, just to repeat, make sure you answer all three polling questions. I'll go ahead and launch them when we get to the point, to the slide where they're on, and we will give folks about 60 seconds to answer them. And I think that is it. There's a Q&A module, so if you have any questions, please feel free to type them in the Q&A, and we will get to them at the end of the presentation. And I think that is it. So without further ado, I will quickly introduce, I'm very excited to introduce our two panelists today. We have Leslie Bowles with us, who is the co-owner and president of Review Healthcare, and Sam Cunningham, who's an HIM professional with 15 years of experience serving payers and providers. So without further ado, I'll go ahead and hand it over to Leslie and Sam.
Well, thank you so much. So we are very excited to be here. Go ahead, Sam.
I was gonna say, you want to give a little more, a bit of a bio, and we'll go right into it.
Sure, absolutely. Well, we're very excited for the opportunity to be presenting today. We just want to thank the Maryland HFMA chapter for the opportunity. As you can see by our bios, both Sam and I have been in healthcare compliance, the world of coding, HIM, documentation compliance for a very long time. I know both of us may look like we're 8 years old, but we have a lot of years of experience behind us. And as you can see with the many letters behind both of our names, that we really like coding a lot. So we are well qualified to speak on the subject matter. We hope that you find today's session very engaging and you have lots of questions for us.
Thanks there, Leslie. Sam Cunningham, yeah, HIM coding professional, been in this for quite a while. If you were to ask me as a Temple University HIM student if I'd get into coding, I would have told you absolutely not. And then here I am today presenting on coding. So very happy to, and excited to dive into this jam-packed agenda. I'm moving on to our agenda. We're gonna cover some of, objectives, a promise, disclaimer. We have a lot of clinical areas that we're going to be covering. Not all these areas we're going to dive into super deep, but we do encourage you to ask questions and to follow up afterwards. We will have some additional details and slides if available, if that's what you need, but feel free to reach out to us at the end. We'll cover regulatory changes as well as regulatory enforcement activities, so things that are hot and that are ongoing, that the government is currently regulating and enforcing as recently as this November. And then we'll close out with some things, some food for thought for forward-thinking topic areas that may not necessarily be a 2024 update, but are things that will have impacts going through 2024, going all the way out to 2030. Some of these regulations do impact. So our objective, to share and learn about significant CPT updates being implemented by the American Medical Association, AMA, for January 1, 2024. This session will also cover regulatory updates and enforcement actions for 2024. By the end of this presentation, you will know more about the key CPT coding updates, regulations, and regulatory enforcement actions, and how to prepare your organization from both a payment integrity and compliance perspective. So get ready to master the year ahead with insights, clarity, and confidence. But before we get into all that, we do have some disclaimers. This is a high-level overview of the CPT changes and updates for 2024. It is not an all-encompassing review, and audience members are encouraged to go further than the material presented herein. The additions and updates to CPT codes are not a guarantee for payment. To lay that out there. Audience members are encouraged to obtain direct guidance from payers regarding coverage and payment. And then lastly, CPT is copyright 2023 American Medical Association, all rights reserved. CPT is a registered trademark of the American Medical Association. And now we have our first polling question. Lucas, do you mind reading that?
Not at all. I'm going to go ahead and launch it here. So you should, everyone should be able to answer the polling question here in one moment. Okay. All right. So what 2024 changes are you most interested in? E&M revisions, immunization updates, telehealth, social determinants of health, or regulatory changes like Price Transparency and No Surprises Act? Again, as a reminder, we'll leave this up for about 60 seconds for folks to respond. All right, about 15 more seconds. Okay, see if we can go ahead and share the results here. All right, can you see the results, Sam and Leslie?
Yes, we can. Thank you for that.
Absolutely.
Well, I'm glad E&M got some traction there because that's where we'll be headed here shortly.
Here, I'll go ahead and pull the results up again.
Yes, thank you. As well as regulatory changes. So foreshadowing the rest of this presentation, we most certainly are capturing our E&M regulatory changes. We do have things dedicated towards regulatory changes at the end. However, almost every single one of these slides has some sort of fingerprint of a regulatory change. The nature of this entire conversation are changes for 2024, as they relate to also big regulatory changes as well. Thanks there, Lucas.
Sure.
All right, next slide. Now, this is a great slide. It's a summary of all the changes for 2024. 349 editorial changes, 230 additional codes, 49 deletions, 70 revisions, as well as Spanish descriptors. I think this is one slide in which you can make a print of and have on the handy when people ask about that CPT changes presentation and what was it all about and what exactly was changed. Which brings me to handing this off to Leslie to go into Spanish updates.
Sure. All right. Thank you, Sam. So it's so great to hear that everybody's interested in evaluation and management changes because there are quite a few here that we're happy to share with you. But let's start with this particular update. So as of the new year, Spanish language descriptors are now going to be offered for more than 11,000 medical procedures and services. So the hope in doing this is that there is a more consumer-friendly, inclusive descriptor that will be an important resource that are clear and straightforward and help engage the Spanish-speaking community. So this was one particular update that we really wanted to highlight for you all. On the next slide. So this is an interesting one. Regarding E&M codes, there is removal of time ranges from office or other outpatient visit codes. So you see here, they give you the range of codes that this directly impacts. CPT codes 99202 to 99205, along with your established office visit codes 99212 to 99215. And this aligns with the format with other E&M codes. There's also instructions that have changes regarding reporting hospital inpatient or observation care services and admission and discharge services for the use of codes 99234 to 99236. When the patient stay crosses. Sam, did I?
Oh, no,
Can you
sorry.
guys hear me okay?
Just a little bit misaligned here. I was just going to interrupt there for a second. The other interesting part about 99202 through 205, 99212 through 215 is that within that descriptor for 2024, they removed time. So, and it doesn't sound like a terribly big deal, but time has been removed from those two codes.
Yes, no, that is a very big deal. Thanks for pointing that out. I want to make sure that we highlight that time has been removed from those particular CPT codes. But just going back to that second paragraph there are new changes to instructions regarding hospital inpatient or observation care services for CPT codes 99234 to 99236 when the patient stay crosses over 2 calendar dates. So I strongly encourage for all of you that definitely have, which all of us are participating in, right? Placing patients in observation status and the like, and our inpatient admissions to take a look at these new instructional changes for these codes. All right, we can move to the next slide. All right, so one of my favorite topics to talk about is split shared and incident 2. So there has been a lot of discussion around split shared and what's going to happen with it, and some of the interesting newer requirements that came about over the last year or so. But for 2024, one of the significant updates is that the definition of the substantive portion of a split shared E&M visit has been changed to in which a physician and when a physician and a non-physician practitioner work jointly to furnish all of the work related to the visit, the substantive portion of it means more than half of the total time, or a substantive part of the medical decision-making. So just to take it back just for a second, when billing for split share, the way it works is whoever has performed out of that physician or the non-physician practitioner, the substantive portion, that is the individual, based off of documentation as well, that is the individual in which you bill that service under. So substantive means more than half of the total time, so they're a little clearer on this. There's a documentation requirement of the total time, so that means that the documentation has to support total time, or documentation needs to support clearly which parts of the MDM were determined by which provider, so whether it was the NPP or physician. We've included this handy dandy table down at the bottom. We've used a lot of the references from the AMA, but also Novitas, which is the Medicare administrative contractor there in Maryland, has a plethora of resources that are super helpful when it comes to working through the substantive portion. So the table on the bottom gives you the definition as it relates to the information that I just went over. So very, very interesting. I know there was a lot of confusion in regards to how to determine substantive portion, and here it's sort of a clearer definition or clearer consensus on what it means from a documentation standpoint and a performance standpoint. Okay, Sam.
And Leslie, I'll add definitions are clearly laid out from Novitas around qualifying time, and that's the substantive portion of the exam as well. So I do direct everyone to their MAC. Sure.
No, very good. All right, so some other interesting updates here. CMS will continue to allow for the presence and immediate availability of the supervising practitioner through real-time audio-visual telecommunication technology through December 31st, 2024. As you all know, during the course of the pandemic, there were some supervision allowances related to audiovisual audio-visual telecommunication during the pandemic, and now they're sort of carrying this through. So this definition of immediate availability is now being linked to the supervision through audiovisual telecommunication. So this is going to go through December 31st, 2024. CMS also finalized a policy that allows for virtual direct supervision of services furnished incident to a physician's professional service. So one of the things, I'm a compliance professional, so we use the word caution quite a bit. So what I will caution you on is just ensuring that these allowances that Medicare is allowing from a federal perspective also aligns with what local state and regional regs they have around supervision. This was quite a battle during the course of the pandemic, where you had federal regulations that would allow for regulations such as these or updates such as these, but then states had a different set of rules related to supervision. So you always want to make sure that you have reviewed your local state rules and regs on supervision as well, also from a scope of practice standpoint. I'll just add that in there as well. All right, so we can move to the next slide. Okay, so we have completed the evaluation and management section, and now we're moving to laboratory and pathology. So as you can see by the slide, this is a very chunky update, which is very common for laboratory and pathology when we talk about CPT coding updates. But for the 2024 year, we're going to just walk you through some of the revisions in summary, especially for those of you that have laboratory and pathology departments in your facilities or your hospitals or your entities. This is a good time to pull out your pen and paper and take a look. So there were many additions, revisions, and deletions to lab and pathology codes, specifically starting with Tier 1 and Tier 2 molecular pathology procedures. So there were 7 revisions to address intellectual disability. So prior to these revisions, there were a different set of wording that was used to describe intellectual disability, which is no longer the case. The way we classify it or categorize it is intellectual disability. So these codes under molecular pathology procedures were updated and revised to reflect that change. Under the category of genomic sequencing, there is one new CPT code, 81517, and this has to do with multi-assays, MAA, so that's one particular code to take a look at. Under the chemistry section, there is one new CPT code for 82166. Immunology, there were 4 new CPT codes, 86041, 86042, 86043, 86366. Interestingly enough, under microbiology, there are 2 new CPT codes. CPT code 87523, that one represents the testing, diagnostic testing for hepatitis D. And then there is a new CPT code that represents orthopox and monkeypox. So that new CPT code is 87593. Under digitization for hematology, cytopathology, and surgical pathology, there is a new T code, 0837T. What we wanted to highlight, and you might hear us say this quite a bit as we go throughout the presentation, what we wanted to highlight with T codes is they are considered Category 3 codes. If you know anything about Category 3 codes, all of the format looks like this. They start with a numerical portion in the front, and then there's a T at the end. What that T represents is emerging technology, right? So this is new advanced technology that is happening in that particular specialty or area. And so they'll designate a Category 3 code. I always like to call it like it's almost like a temporary code for that particular advancement in technology. Sometimes those T codes are sunsetted, or sometimes they are categorized or moved into the category of Category 1, which is a complete numerical code, 5-digit code. So I would keep my eye on these T codes. You're going to hear us talk about T codes in a lot of other areas and specialties. T codes too, I will also say oftentimes there is a very interesting take on how they are paid. So when you are utilizing T codes, especially with some of your federal and your commercial payers, managed care, you want to make sure that you have a full understanding of payment prior to submission because of the unique approach to T codes. All right, so moving on to the PLA codes, proprietary laboratory analysis code. So there was a total of, and this is always a very, very robust section. So there was a total of 61 new codes, 10 revisions, 15 deletions, and then in the appendices for the PLA codes, there were 2 specific changes. So as we mentioned in the disclaimer, if you are an organization that utilizes PLA codes or laboratory or facility entity with a pathology department, we really advise you to sort of dive deep into this summary that we've provided for you. Something else that is more of a regulatory change, but is appropriate here in this section, diabetes screening. So this was interesting. Medicare finalized coverage for hemoglobin A1C lab tests, right? So the CPT code being 83036. So diabetes screenings, D13.1 billed with an evaluation and management code, Medicare is now finalizing coverage and saying, yes, we will pay for it with that ICD-10 code along with that E&M CPT code for that particular test. So very interesting, was a point of contention for some time, but now they are sort of just making their final stamp on it and saying, yes, we will absolutely cover it. So good news there. Sam, did you want to add anything else or?
Yeah,
Okay.
I'll just add that the diabetes screening for a variety of different payers, you probably all the audience on this call may have experienced denials for the screenings. Not saying that in the future there's going to be any less denials, but there's at least some traction around people putting attention to these diabetes screenings strictly for diabetes screenings. That's all I'd add.
Yeah, no, I'm in complete agreement. There is no promise to pay ever, but it's nice to know that the coverage allowance is there. All right, so moving right along for CPT updates for urology. And just as a reminder, if you have a question regarding a certain section, we do have someone who's fielding the questions, so feel free to go ahead and put them in the Q&A or the chat so that we can address them at the end. All right, so for urology, so quite a bit of changes here, but we'll go through the different categories that these changes are applicable to. So cystourethroskopy, which is a mouthful to say, with urethral dilation and urethral therapeutic drug delivery, there is a new category 1 code for that. So it's CPT code 52284. And here's a great example of a T code that was replaced, a category 3 code, with a category 1 code. So this was previously a procedure that was under CPT code 0499T that is now deleted because of this new addition of the category 1 code. Neurostimulator services. So there are revised category 1 codes for CPT codes 64590 and 64595. In addition to that, there are 3 new category 3 codes. So these are CPT code 0786T through 0789T. So as a reminder, remembering that these are categorized as emerging technology codes. Then the next one being tibial neurostimulator services for bladder dysfunction. So there are new category 3 codes. There's actually 4 of them. CPT code 0816T, 0817T, 0818T, and then 0819T. There's also revised category 3 codes that are in alignment with these changes, 0587T and then 0590T. So a lot of T codes this year. Next one, remote inpatient multi-day comprehensive uroflowmetry. So there are 3 new category 3 codes. Sorry, 2. I'm seeing category 3 and getting confused. 2, 0811T and then 0812T. So this is usually 7 to 10 days of monitoring as opposed to 99453 and 99454 that require 16 days of monitoring. So the difference between the two is the duration of the monitoring associated with this particular test. And then we have an additional category 3 code. So this is low intensity ESWT. So the new code for that is 0864T. So again, a lot of new emerging technology or advances in technology codes. It's very interesting as we move along. We can move to the next slide. Thank you, Sam. So under neurosurgery, another T code. You're going to hear me say this quite a bit. So electrophysiological focused magnetic stimulation, 0858T is the new category 3 code for that. There's also revisions to descriptors for peripheral nerve transcutaneous magnetic stimulation. These are 0766T to 0769T. So what the revision was there, they removed the wording initial treatment from the descriptor. And sometimes when we think about these revisions to the descriptions, we'll say, oh, that's minor, but it can have a huge impact on the code itself. So I think we are going to be speaking about a lot of new CPT codes, but the revisions are equally as important, especially when it comes to updating your charge description master individually or departments and the like. There were parenthetical revisions related to revision or removal of gastric neurostimulator, so CPT code 43882. There are new codes that were introduced. These are category 1 codes, skull-mounted cranial neurostimulator. So CPT code 61889, 61891, 61892. So what's interesting about these codes is that it represents a different approach for how this neurostimulator is mounted. And then the newer codes include revision, removal, insertion, all of that good stuff associated with that particular procedure. Some additional bullet points here that I think are important to mention along with skull-mounted cranial neurostimulator, these new CPT codes. 61889 includes craniectomy or craniotomy, coupling and connection of electrode arrays. And then 61891 is connection of electrode arrays. And then 61892 is the cranioplasty. All right, so for spinal peripheral neurostimulator services, there was quite a few revised descriptions. So again, just paying attention, taking a look at these because these will directly impact your charge description master if you're utilizing these or performing these services at your organization. So this was applicable to the codes that you saw on that slide. All right, so moving right along to ophthalmology. There were 2 new codes, one related to injection. So this is 67516. This CPT code will replace the deleted code 0465T. So this is another example of an emerging technology code that was replaced category 3 with a category 1 code. There's also the subretinal drug delivery injection. It's a new code for that. This one was a category 3 code, emerging technology 0810T. And then there was also, along with this, the AMA, the RUC group, they reviewed potentially misvalued services associated with this procedure as well. Another thing that we wanted to highlight, which was very interesting, I always think it's important to mention this, especially from RVU standpoint, for all of you that have RVU-based contracts and you have ophthalmologists in your organization, there was a decrease in RVUs for the following ophthalmology procedures. So ocular surface, amniotic membrane placement, and reconstruction. So this is for CPT code 65778 to 65780. So this was quite a significant decrease. So we wanted to make sure that we highlighted that for you all. So I'll turn it over back to you, Sam.
All right. Thank you, Leslie. All right, so digital medicine had quite a few updates, and I apologize if I'm reading straight from my notes, but I want to make sure that I get it 100% correct. Digital medicine in that category, we did have category 3 codes for virtual reality and facilitated motor cognitive training, 0791T. That's going to be coded in conjunction with 97116. So this is virtual reality, gait training. Pretty interesting things. It's a therapeutic procedure for one or more areas. That's a time-based, each 15 minutes, therapeutic exercise to develop strength and endurance, range of motion, and flexibility. So interesting with the virtual reality aspect here. The next new code is the pharmaco-oncologic algorithmic treatment ranking 0794T. Now, this is artificial intelligence used for utilization of rules-based algorithms to detect clinically relevant data. This is the beginning phases and will likely take on more of a role for reimbursement in the future due to utilization. So this is technology that is suggestive, AI that's suggestive, and the clinical information that is produced here is suggesting diagnoses. It's still up to the professional to confirm these. So the code 0794T is to account for professional time to complete and submit the patient's clinical data for the algorithmic assessment. And that's all included within that code. It's the intentions. The next revision, so those the technology, the AI, the virtual reality, it flows down into these appendices. So the first revision for Appendix S, which is reserved for artificial intelligence taxonomy for medical services and procedures, have added this code. And they've also added additional definitions as it relates to this technology. So we're talking about augmented versus autonomous. And I would encourage everyone to go to that section of the appendix to read about these things. I think it's interesting just from an AI perspective of what does it all mean and how is it impacting healthcare. They try to address a lot of those issues or topic areas within that appendix. The next appendix, Appendix P and T, has been updated regarding instructions for telehealth services. So Appendix P, that one's reserved for audio and visual. And within that appendix, we have some updates as it relates to services for audio and visual need to be services that you could equally do in a face-to-face kind of environment. And then they also provide instructions for a pending modifier 95. Now, having done some telehealth over the past few years, payer specific, please go seek your payer guidelines for your telehealth claims. Appendix T, similar to Appendix P, is just for the audio portion. Again, typically these are services that would otherwise be done face-to-face, but applying modifier 93. Again, this is audio only. And lastly, not to say things twice or 3 times here, but please defer to your state and payer specific guidelines for modifier usage. What else do I want to say about this? So for both Appendix P and T, there is also some criteria established within there. I think the intentions for the criteria are to give an example of when telehealth is an acceptable service, and some of those broad categories are that it needs to be some sort of efficacy to the service. There needs to be some sort of cost savings, and that it needs to, just an example, increase recovery time. So those are the kinds of categories that the AMA is considering as they're writing out Appendix P and T, is that telehealth services needs to fulfill some of these basic criteria and requirements. we've had some updates for COVID-19 and immunizations, not just for COVID-19, but also RSV, and we'll get to RSV here shortly. In the past, we've had over 50 some odd previous codes. They have all been consolidated. Post PHE pandemic ending, we have now moved on to FDA approvals for these drugs. We have new drugs. We have not new drugs, but we have new codes for these drugs that have received FDA approval as of September 11th, 2023. That's for both Moderna and Pfizer. These codes have gone into effect, and unlike other codes that for immunizations, these are live codes. These are not waiting for January 1, so they're effective as of the FDA approval date. New code 90480 is an administration of the COVID-19 vaccine. This will be added in conjunction with the aforementioned codes for COVID there, that 91318 through 91322. All existing CPT codes for vaccine products associated with administrative codes that end in a letter A, and now there's quite a few other category 1 codes in there as well that are no longer covered. They're no longer covered by the emergency use authorization or the biologics license application, and were deleted and no longer relevant or no longer applicable post November 1 of this year. So it's something to take into consideration. It's a 2024 update that we got a little bit early. RSV. I do encourage everyone to go to this link. There's been quite a few updates as it relates to RSV immunizations. We have these 5 new codes. They do vary in degrees of, I believe it's patient age is one factor between the differences in the codes. The link here does provide long descriptions as well as implementations. The codes have different timelines on whenever they were approved and published. And we also have a new code for pentavalent meningococcal vaccine that has been added for treating a meningitis 90623. All right, orthopedic surgery. Through here. We have some new codes as it relates to vertebral body tethering. 4 new codes, 22836, 22837, 38, and 0790T. And we also have 2 revised codes, 06560, 06570. Also, we have metatarsal arthrodesis for bunion correction, 6 revised codes, 22892, and then we have 22895 or 2295 through 28299. This now includes language that a bunionectomy was performed. So that was the new addition to the parenthetical and the descriptions. We also have insertion of calcium-based implant for the femur. 1 new code, 0814T. It was established for percutaneous osteoconductive material. Previously, no code existed for this insertion of the calcium. And now, just as an example, because I know that seems wildly complicated, imagine a femur fracture with fixation, where the calcium-based biodegradable osteoconductive material was used to help with that treatment. All right, occupational therapy. We have some new codes for caregiver training, 97550 through 97552. The interesting thing about these codes is that they're not involving a patient. So this is not with a patient. This is codes that are unique in that they do not involve a patient, but involves training of caregivers. I don't know if any other codes like that are particularly existing in prior years. However, this is interesting for this year. We will go into why that's so interesting as we get into our regulatory updates. It is a push, as we see in a lot of the regulations, for more continuity of care, but also access to care as well. So we also have a new code, postoperative low-level laser therapy 97037. This is a new code. As Leslie pointed out earlier, there are no RVUs associated with this code. As with a lot of our technology codes and our category 3 codes and codes that do not have RVUs, we do find that it's still important to track and trend these services and the costs related to them. And then as related to occupational therapy, so the AMA is emphasizing more so, not just for occupational therapy, but for both PT and OT, that supervision and the components of a PT and OT eval, which history, exam, clinical decision-making, and plan of care are clearly documented. They, as part of the AMA a couple weeks ago, this was, discussed. And I guess the idea or the intentions here are that the documentation has been lacking in these areas. So they felt that though it's not a change, that it's worth emphasizing. All right, otolaryngology. We have some new codes for posterior nasal nerve ablation, 31242, and 31423. These are ablation codes that are bilateral, and the update here, or the unique thing here, is that if you're going to go unilateral, that you use modifier 52. Now, auditory osteo integrated device services. There's new codes for 92622 and 92623. These are time-based codes, respectively, 60 minutes for the one ending in 22 and 15 minutes for the one ending in 23. These are for diagnostic analysis, programming, and verification of an auditory osteo-integrated sound processor. Nothing more to add on that. All right, we're starting to get into the more complicated stuff. Radiology, interventional radiology, and soon to get into cardiology. We have some new codes. New code for dorsal sacroiliac joint arthrodesis, 27278, which replaces 075T. For percutaneous transfixation devices, C27279. So part of a lot of these updates also includes instruction notes to go to other codes. Pulmonary tissue ventilation analysis, 0807T and 0808T. New codes there. Ultrasound-based radiofrequency echocardiograph, multi-spectrometry, REMS, axial bone density study, 0815T, code there. New code for optoacoustic imaging for breast masses, unilateral, 0857T. And new code for quantitative magnetic resonance imaging, MRI analysis of brain with comparison, 0865T. And then new codes for spectroscopy study, Wunder flap revision, and new. So 0640T and 0859T, with the deletion of prior code 0641T and 0642T. Also, there was a review of potential misvalued services, and I want to go in a little bit with a little bit more detail here. These codes were once reimbursed, but Medicare has categorized them as a practice expense. So the codes that are listed out here are neuromuscular ultrasound is now a practice expense. And this is done intraoperatively. So these intraoperative ultrasounds are now practice expense and likely no monetary value to them. The best example of these would be someone coming in for ankle pain. They have some radiographs done, and the radiographs are negative, but an ultrasound is still being conducted to further evaluate the patient's injury. So those will now be practice expenses. Which brings us on to cardiology. So we have some new codes, percutaneous transluminal coronary lithotripsy 92972. This code replaces the category 3 code 0715T. 92972 is an add-on code to be reported with other coronary intervention procedures. So interesting part there, it's an add-on code. Venography services, we have 5 new add-on codes, so 93584 through 93588. These codes are to be used for reporting the treatment of congenital heart defects via venography. And then we also have radiological supervision and interpretation are also included within the definitions. We have a new code for transcatheter pulmonary artery denervation 0793T. Also a new code for dual chamber leadless pacemaker 0795T. And through 0804T. Also new codes for superior vena cava, SVC, inferior vena cava, IVC, prosthetic valve insertion 0805T and 0806T. To go to my notes here, these procedures didn't exist prior. That's for insertion of the valve. No code existed prior to 2024. These are used for treatment of a tricuspid valve regurgitation. Also, we have some new codes for wireless cardiac stimulation system for left ventricular pacing 0517T through 0520T, and also 0861T through 0863T. All right, we're keeping on with cardiology. New codes for right atrial leadless pacemaker, 0823T, 0824T, 0825T, and 0826T. Identify placement, removal, revision, and programming services for right atrial, single chamber, leadless pacemaker devices when done for the right atrial, single chamber, leadless pacemakers only. Do not use these codes if, all right, so important notes here as part of these code usage, an existing right ventricular device has already been placed, or the right atrial component of a dual chamber system is being placed with the intent of placement of a right ventricular device at a later time. New codes for near infrared spectroscopy, NIRS, NIRS, for peripheral artery disease, 0859T and 0860T. All right, so we have some new codes for phrenic nerve stimulation system. I'm not going to read off all of those, so I'll spare you that. These services may be used to treat moderate to severe central sleep apnea by stimulation of the phrenic nerve to control breathing. These new codes in this 30,000 series are to cover insertion, removal, and replacement of the phrenic nerve stimulator. So read each one of these. Not all of the codes do the exact same thing. Some of them are insertion, some of them are removal, some of them are replacements. These new 90,000 series codes are to cover the programming aspect of the stimulator. New code for fractional flow reserve was CT, so FFR was CT, that's 75580. is an FFR with CT that replaces 0501T through 0504T for the 3D software imaging and augmentation. And I refer everyone back to the digital medicine slide. I think this is where the FFR will come into play when it comes to the artificial intelligence when used. So FFR, when used with artificial intelligence, would end up using that category 3 code as mentioned on the digital medicine slide. New codes for intraoperative thoracic aorta ultrasound services. So it was 76984, 87, 88, and 89, with a revision to 76998. These codes were created to increase the specificity of 76998, which was just ultrasound intraoperatively. So we've got more details with these additional codes. The new codes are to identify diagnostic intraoperative ultrasounds for cardiothoracic surgery according to the anatomy treated. So the codes are broken out by anatomy. For example, the epi-aortic ultrasound is the 76984, and congenital epicardial echocardiography is the 76987 through 76989. In short, they provide specificity and they have varying degrees of payment associated with each one of those intraoperative ultrasounds. And at that, I think I'll get a drink of water and hand it over to Leslie.
Thanks, Sam. That was a lot to go through for the cardiology section. So for those of you that are updating the cardiology CDM, our heart goes out to you for this upcoming year. So you're probably asking yourself, why do we have social determinant of health ICD-10 codes in this presentation? We're talking about CPT. Well, these codes, these diagnosis codes are becoming increasingly important. And there were some significant changes, revisions and additions that were associated with SDOH that we wanted to share with all of you. So starting with these slides, this particular slide, it introduces new ICD-10 diagnosis codes that were effective October 1st, 2023, but we wanted to highlight them for you here. Now, just to go back for a second, what are social determinant of health codes? Well, these are codes or conditions, factors that the patient may have that may impact the diagnosis condition that the physician or practitioner is treating. So I always like to give this example to folks so they can better understand it. If you have a patient who has developed hives and they come in to see the physician and they say, you know, I have these hives, and they tend to break out every time my mother-in-law, who just moved in with us, walks into our kitchen. That's an example of a social determinant of health, just to give you a little comedy there. So when we're talking about social determinants of health, it is a external factor or a particular reason as to why a diagnosis or condition is impacted. So let's just take a look at some of these ICD-10 codes that may be of interest to you and your organization. One of the things that I do want to add here, that these codes are secondary codes, okay? So just something to be very mindful of when utilizing them. They are used to support the diagnosis or condition that it is associated with. So Z62.23, child in custody of non-parental relative, Z62.24, child in custody of non-relative guardian, Z62.823, parent-stepchild conflict, Z62.83, non-parental relative or guardian child conflict, Z62.831, non-parental relative child conflict, Z62.832, non-relative guardian child conflict, Z62.833, group home staff child conflict, and then Z62.892, run away from current living environment. So new diagnosis codes for you to consider there. Another really important factor on the next slide is also effective October 1st, 2023, MSDRGs have added the following SDOH codes as complication or comorbidity, CC. This is the first time this is ever happening. This is really big. So 3 of these codes, Z59.00 homelessness, unspecified, Z59.01 sheltered homelessness, Z59.02 unsheltered homelessness, are 3 new codes, CC codes. I think we have a question related to, Markia, I think you were asking a question there. I see you have a hand raised.
Yeah, so we have a question in the chat. Is new code 33276 replacing deleted 0424T by Kelly?
Okay, so that's going back to the cardiology section. What we can do, Kelly, is have Sam answer you in the Q&A box for you so that he can get that over to you. Thank you for your question. All right, so going back to the SDOH updates here, again, new CCs that are really, really important, especially from DRG standpoint for your consideration. All right, we can move to the next slide. So this is also a very interesting update going back to CPT. So this is a new HCPCS code, G2211. So what the description of this code is visit complexity inherent to evaluation and management associated with medical care services that serve as the continuing focal point for all needed healthcare services and/or with medical care services that are part of ongoing care related to a patient's single serious condition or a complex condition. So this is an add-on code for office and other outpatient services. The thought process is this will be primarily used in primary care for new and established patients. And Medicare is finalizing, CMS is finalizing coding and payment changes to better account for community healthcare workers, care navigators, and peer support specialists. So we're going to talk a little bit more about this, about the Biden-Harris administration and what they're doing right now as far as advancing healthcare equity and the like. So a lot of these changes that we're going to be talking about fall under that initiative. So they give an example here of when to use G221. So the severity of the patient's chronic condition is affected by an SDOH, and it's good that we just discussed what that is. And so longer time is spent on patient education to increase patient care compliance. So they're giving you an example of when it is appropriate to utilize G2211. They have an example of when not to use it because it's equally as important to know when to use it versus when not to use it. So this is an example. Do not use it with modifier 25 or simple procedures like mole removals, treatment of a simple virus, new onset GERD. They give some diagnosis or condition examples there. When the billing practitioner has not taken responsibility for ongoing medical care for that particular patient with consistency and continuity over time, or does not plan to take responsibility for subsequent ongoing medical care for that particular patient with consistency and continuity over time. So one of the key factors here that you want to keep in mind, and if you plan on educating your providers and practitioners on this new add-on code, you want to make sure that they understand that there is a component of consistency and continuity of care that matters here when it comes to requirements for use of this code. So we can move to the next slide. So there were lots of new updates in regards to behavioral health services. You know, I have worked in healthcare for a long time. I was really impressed, and this one was actually a really good update. So for the upcoming year, Medicare Part B coverage and payment under the Medicare physician fee schedule for the services of marriage and family therapists and mental health counselors when billed by these professionals. So this is breaking news for the first time ever. Medicare is paying for services provided by mental health counselors and licensed marriage and family therapists. Additionally, addiction counselors or drug and alcohol counselors who meet the applicable requirements to be an MHC, which is really important here, they can enroll in Medicare's MHCs and also bill for their services. So really great stuff for those of us that have outpatient counselors or counseling departments or therapy departments, something to consider there for your organization. MSCs and MHCs will also be able to begin submitting Medicare enrollment applications after the physician fee schedule final rule was issued, which was in the first part of this month. So they're actually taking credentialing applications now, and they will be able to bill Medicare for services starting January 1, 2024. So just for clarity, Medicare is allowing these practitioners or these counselors and therapists to enroll in Medicare as providers now, but the billing will start January 1, 2024. Some other additional changes that are equally as important: behavioral health integration codes are now going to be allowed to use by MSTs and MHCs, so they can bill for these behavioral health integration codes. Currently, MSTs and MHCs, the therapists and counselors, cannot bill the crisis services 90839, which is psychotherapy for crisis. However, there will be HCPCS codes that are expected, so keep an eye out for that as well. Another very interesting fact here: health behavior assessment and intervention, so they're HBAI 96156, 96158, 59, 64, 65, and 67, and 68 can be billed by MSTs and MHCs starting January 1, 2024. So action-packed, a lot of information there, from enrollment to new ways of being able to bill for services. So very important stuff there.
Honestly, I think
All
the
right,
other
we can move
thing to
on.
note was just around the history that historically these were licensed social workers that were able to provide these services only.
Right, absolutely. So they're licensed clinical social workers, yes. So I think it's just really impactful that the federal government is recognizing the work of counselors and therapists, which is contributing to this very, very monumental change. So we're excited for the counseling community. All right, also, just big news regarding dental, because dental has always been statutorily excluded when it comes to Medicare, right, except for certain circumstances. But for the new year, payment for dental services that are inextricably lined to other covered medical services, such as dental exams and necessary treatments prior to organ transplant. They give some examples to include stem cell and bone marrow transplant, chemotherapy, cardiac valve replacements, and valvuloplasty procedures. If those dental services are linked to treatments such as these, then they will be considered covered medical services. So something really, really important to note there when it comes to dental services for your organization. Sam, I believe we have a polling question.
All right, I will go ahead and launch it. And just as a reminder, as I'm getting ready to launch the polling question, we'll leave it up for about 60 seconds for folks to respond. Okay, so what 2024 regulatory changes are you most interested in? IPPS, OPPS, COVID-19, PHE, price transparency, or other? All right, we'll leave it up for about 20 more seconds. All right, last chance. Okay, I'll go ahead and end the poll and we'll share the results. So we had 29% say IPPS, 53% over half say OPPS, COVID-19 PHE 16%, 46% said price transparency, and 10% said other.
All right, appreciate that there, Lucas.
Sure.
That poll is foreshadowing our next group of slides as we dive into regulations. I think it's important to underpin that all the regulations that we're already to talk through are by way of the Biden-Harris administration, and they've established by way of these executive orders. And I knew it wouldn't be a good way to present any of these, is all the names of all these executive orders. They have these complicated names. They are ambiguous, and I didn't think that they probably add more confusion. So let's just call them all the executive orders from the Biden-Harris administration. The initiatives for all of these are to expand care delivery. The regulatory changes in the following slides provide additional detail into the administrations and regulations of these initiatives. These changes disrupt other forms of care that have typically been seen as not cost effective or disproportionately serve or not serving certain patient demographics. The efficacy, so an important note here is the efficacy of these services has not been fully determined. So these are new initiatives, and we're preparing and hoping that they are going to achieve their objectives. Important notes here. So the PHE did end May 11th, 2023. There are some key regulations that are reverting back to 2019 way of life, to the rules back in 2019 and prior. And the expirations of PHE waivers. So be mindful of those. Some things that have been extended into the future includes telehealth, variety of other waivers. Some of them are hybrid type waiver extensions, but as we've seen in other states, in particular for telehealth, some states have taken on different approaches of whenever they're going to sunset or continue on certain telehealth services. SNP 3-day inpatient qualifying stay. That was a 2019. Actually, it was for forever, the 3-day qualifying stay. The waivers during the pandemic waived the 3-day inpatient qualifying stay. Since May 11th, that has since changed. I have seen in other states that for Medicaid in particular, they've taken different approaches. Again, defer you to your state Medicaid or your payer requirements there. Again, incident 2 and credentialing. We'll get into more credentialing as we dive into telehealth, but they all have certain specificities around them, as well as different milestones on when they're going to be either sunset or continued or some sort of hybrid compromise. All right, so OPPS and ASC payment rates are statutorily increasing to 3.1%. Important thing to note is that that's across the board. So there's certain things that are increasing more than 3.1%. As an example, the observation APCs are increasing by 7%. Arthroplasty has a decrease of 4%. Neurology, as an example, has an increased payment of 1%. Intensive outpatient program, IOP. Now, this is a billable Medicare service that is intended for patients requiring greater than outpatient and lesser than inpatient care. This is, I think it's worth an additional read from all audience members of what this is. And now, again, this is trying, as for the Biden-Harris administration and executive orders for increasing care in a cost-effective way. This would be, again, another one of those initiatives. The scope of these services are outpatient psychiatric services provided for individuals who have an acute mental illness or substance use disorder, consisting of a specified group or behavioral health services paid on a per diem basis. So the services, as they relate to this IOP, are done on per diem basis. Partial hospitalization program, PHP. It's expanding rates for 2 PHP APCs for 1-day and 3-day lengths of stay to, again, be paid on a per diem basis. what else can I say about PHP? Again, yeah, partial hospitalization provides structured program on the outpatient psychiatric services as an alternative to inpatient psychiatric care. Activities related to care coordination and discharge planning, as well as to recognize the role of caregivers and peer support specialists for both the PHPs as well as the IOPs. All right, price transparency. The hospital price transparency requires hospitals to encode its standard charge information in the CMS templates and conform with data dictionary requirements, machine readable file formats. That machine readable file format is new for this year. Additionally, starting as of January 1, 2024, hospitals will be required to append a footer within the hospital's website with a link to the machine readable file. CMS also puts out prescriptive language as an affirmation statement that is required that the machine readable file is, to the best of its knowledge and belief, has included all applicable standard charge information in accordance with the requirements 45 CFR Part 180, and that the information displayed is true, accurate, and complete as of the date indicated in the file. The intentions and the hope for the machine readable file is a net benefit to not just payers, but also providers themselves. So this may help hospitals, may help providers determine fair reimbursement. So the existence of this data may help with leveraging in contract negotiations as well. The idea there. Enforcement actions. So I think this is probably a good time to go into, how is price transparency even being enforced? We have the regulation and we have some enforcement, but how is that being enforced? And for the while there, I feel like the enforcement was more, please do this, with a little bit of shaming. They are currently doing audits. There are coming out of those audits. CMS is making corrective action plans. And then part of those corrective action plans is that the hospital actually closes out those caps. And failure to close out those caps may result in monetary penalties, as well as your facility being published in a public way that you're not adhering to the price transparency rule. Now, there has been some audit activity that has resulted in monetary penalties. They are published on, I believe it's CMS's site, and they have their calculation for determining that monetary penalty. Down below is the math equation. They do $10 times bed count times days not in compliance with that. For organizations that have less than 30 beds, they immediately cut out the bed count calculation and just go to 300 times the days. So an important note for some of the smaller providers out there. It's a good time to transition to Leslie.
Yes, absolutely. And I just wanted to add one thing as it relates to price transparency. One of the things that I encourage you all to do, if you have not gone on the website, the enforcement action website, to see the facilities that have had recent CMP penalties imposed against them, I encourage you to do so, because it also has an example of the letters that were sent to the organization. And some of the reasons why some of these organizations have gotten into trouble with CMS is because of their lack of response, just period, to the letters, and also to the cap request. So I think it's a good educational tool to show your executive teams, especially your finance folks, so they can know what those letters look like and know who to send them to. All right, so we're coming up here, 15 minutes left. We've gotten through the bulk of the presentation. I'm going to be talking about telehealth. So what are the updates related to telehealth? Well, starting in 2024, CMS is removing the telehealth frequency limitations for the following facility E&M services. So subsequent inpatient visits, you have the codes associated with that, subsequent nursing facility visits, critical care consultation codes, consultation service codes, these are G codes, and then administration of SDOH assessment tool, G0136. Audio-only telehealth services will continue to be paid by Medicare through December 31st, 2024. However, there could be payer-specific rules or payers that may not. So you want to make sure you check in with those commercial payers and see their stance on it. The other thing that's really important here to note is to watch these dates, right? This is really important when it comes to telehealth and some of the allowances associated with it. Some other updates: teaching physicians in all training settings need to be present using audio-video real-time communications technology when a resident is providing Medicare telehealth services through December 31st, 2024. And then diabetes self-management training. Medicare is allowing DSNT services to continue to be provided via telehealth. So really important information there. Moving on to permanent CMS changes related to telehealth. Federally qualified health centers, FQHCs, and rural health clinics can serve as a distant site provider for behavioral mental telehealth services. Medicare patients can receive telehealth services for behavioral and mental health care in their home. There are no geographic restrictions for originating site for behavioral and mental telehealth services. If you remember pre-pandemic, there was a lot of restrictions associated with the originating site when it came to the delivery of telehealth to patients. So they're sort of removing those restrictions. Behavioral mental telehealth services can be delivered using audio-only communication platforms. So new, and this is wonderful. I think it's also really important to make sure that you understand for behavioral and mental telehealth services which codes or which type of services can be used or delivered via audio only. And then rural emergency hospitals are eligible originating sites for telehealth. So some interesting changes there. Moving to some more of the additional changes, telehealth coverage and payment determinations for Medicare will be decided through the physician fee schedule. So if it's not on the physician fee schedule, then the telehealth service will not be reimbursed. So this is really important to note. If it's not on your physician fee schedule, and keep in mind, physician fee schedules can be found on cms.gov and then locally through your local Medicare administrative contractor for the state of Maryland, which is Novitas. During the public health emergency, CMS allowed licensed physicians and other practitioners to bill Medicare for services provided outside of their state of enrollment. CMS has determined that when the PHE ends, CMS regulations will continue to defer to state laws. So this was very interesting because during the PHE, there were a lot of federal allowances that state rules and regulations did not align with it. So here they're directly saying we will defer to state law when it comes to physicians and practitioners who are providing telehealth services outside of their state of enrollment. PHE flexibilities were extended to allow practitioners furnishing telehealth services from their homes to report their office addresses on their enrollment form. So very interesting here from a credentialing and enrollment standpoint. If that physician or practitioner is providing telehealth services from their homes, they can use their office address on their enrollment forms. And then there's some additional guidance on modifier usage for telehealth. This link, we've provided a link here that we think will be just really, really helpful when it comes to determining what is the best modifiers to use, the appropriate modifiers to use for some of these scenarios.
And Leslie, I want to add for Maryland Medicaid, they do not pay for audio only and requires that distance site providers be licensed and credentialed in Maryland and providing services within their scope. Maryland is, however, reimbursing telehealth services the same as if they were face-to-face up until June 30th, 2025. So have that date in mind for Maryland Medicaid. Additionally, PHE flexibilities were extended to allow practitioners furnishing telehealth services from their homes to report their office addresses on their enrollment form. So I think we covered that as well. So.
No, good information. It's state specific. We all need to hear what our individual states are doing. All right, so just to go through some of the temporary telehealth changes, temporary Medicare changes through December 31st, 2024 to keep in mind. FQHCs and RHCs can serve as a distance site provider for non-behavioral or mental telehealth services. Medicare patients can receive telehealth services in their home. There's no geographic restriction. Some of this is redundant, but we wanted to make sure that we help you to categorize temporary versus permanent. Some non-behavioral mental telehealth services can be delivered using audio-only communication platforms. An in-person visit within 6 months of an initial behavioral mental telehealth service and annually thereafter is not required. So this is a temporary change through December 31st. I would keep my eye on this one. And telehealth services can be provided by all eligible Medicare providers. All right, so on our next slide, we're just going to dive a little bit deeper into what caregiver training services are. The Biden-Harris administration executive order on increasing access to high quality care and supporting caregivers' health equity is sort of the basis of where these codes originated from. So caregiver training services. So payments will actually be made to practitioners to train caregivers to support patients with certain diseases or illnesses in carrying out a treatment plan. So they give the example here of a patient with dementia. So SDOH G0136, the SDOH risk assessment will be a part of the annual wellness visit with no additional cost to the Medicare patient. I just want to go back for a second to the caregiver training services. When you see these codes, it's interesting because the codes are separated by individual training services to the caregiver of the patient. As Sam mentioned earlier, the patient is not involved, but it's providing training services to the patient's caregiver in an individual setting and in a group setting. So it's really important if you're going to add these codes to your charge description master, you're going to utilize them, that you understand the descriptions and the code requirements, documentation requirements with it. Going back to the risk assessment code G0136, it will be a part of the annual wellness visit with no additional cost to the Medicare patient. There's also new codes related to community health integration services G0019 and G0022, along with principal illness navigation services G002324, G0140, and G0146. So all a part of the Biden-Harris's executive order. So moving along, I think this is really important. Sam, this is you. I'm jumping ahead. Go ahead. Inpatient only list.
Yeah, inpatient only list. I could read this all off to you, but we're coming off short on time and patience. But there are new inpatient only list codes that have been added for this year. They are vertebral tethering procedures, neurostimulator insertion, cardiac ultrasound procedures, and transcatheter tricuspid valve implantations. I think it's important to take note of these new additions and incorporate. Two-midnight rule. This rule has been around for quite a while. The only thing new and interesting for coming up on 2024 is that Medicare Advantage will now be required to adhere to the two-midnight rule. So it prohibits Medicare Advantage plans from limiting or denying coverage for Medicare covered services based on its own internal or proprietary criteria if such restrictions do not exist in traditional Medicare. So the Medicare Advantage plans are required to adhere to the two-midnight rule for coverage of implant or inpatient admissions effective calendar year 2024. All right, so, and I think, Leslie, I think we could probably tag team this one, but recent enforcement activity, HHS, OIG, Department of Justice, state, local Department of Justice, all have these as categories in which they're enforcing and penalizing non-compliance with things as, I won't go down the list here, but first one, anti-kickback statute and Stark law violations. So these are organizations that, are not only getting a civil, but also criminal penalties associated with them. We encourage, from a compliance perspective, to do at least an annual assessment of your contracts. There's a lot of good information, as you can read, on maybe leading practices as it relates to organizations that have gotten themselves into trouble and have since received a corporate integrity agreement, which lays out a fairly nice blueprint for how to keep your noses clean. We encourage providers to do annual assessments of the focus arrangements as it relates to compliance with the Stark Law and anti-kickback statute. That includes fair market evaluations, having the appropriate business and legal reviews, as well as testing the contracts for remuneration, that it's appropriate and in line with the contractual terms.
Yeah.
Leslie, anything else you want to add to that?
No, yeah, I was going to say, and just all of this stuff that we're doing today and going over are proactive actions towards ensuring compliant practices at your organization. You know, some of the things that you should think about, as mentioned here on the slide, especially related to coding and you know, all of these new CPT code updates that we have, is just ensuring that you're auditing to ensure accuracy of the information on claims in the charge description master. But also we're seeing such a huge increase of medical necessity reviews on all different levels of service, from outpatient to obs to inpatient. So something to think about here, if you see that second bullet there, medically unnecessary services is a huge area of these agencies, as Sam has mentioned. Falsifying documentation, believe it or not, is still very much so happening, adding unnecessary medically services to claims and the like, false claims, using other provider numbers, using incorrect information, or using maybe the credentials of a physician who's on vacation in Hawaii, right? Looking at some of these things are really, really important. And then to the last one, risk adjustment. There's a lot of enforcement activity around risk adjustment. I know this is a CPT coding update, but when it comes to ICD-10 diagnosis coding, there is a lot of enforcement activity amongst payers and what Medicare is doing with Medicare Advantage. So something to think about there.
Yeah, and forward thinking beyond January 1, as we just got done talking about risk adjustment, there is, and I think this is fairly important, a model change for Medicare Advantage, or Medicare's risk adjustment model. It doesn't take a dramatic shift, but it's a shift enough in which I think a lot of organizations should do a shift analysis, assuming nothing changes with your patient population, that you understand and are actually able to predict a financial sway. Again, social determinants of health are continuously going to be discussed, but they're not fully adapted in the fee-for-service world or the risk adjustment models. We are anxiously anticipating how those are going to be utilized in the future. We've covered a couple of those topics. HEDIS stars, quality measures, again, something to be mindful of in the future. And then we hit on, I think, a ton of Category 3 technology codes. And I think understanding how those codes are and the costs associated with them are going to be vitally important into the future. I know we're coming up on time, and we've got our next polling question. And this is the same one as our first polling question, so I'm interested to see how anyone's changed over since the beginning of the presentation.
All right, we're going to go ahead and launch it. And again, as a reminder to folks, we'll leave it up for 60 seconds.
And Leslie, I think as we're coming up on time here, I want to make reference that in the presentation, we do have reference material. Again,
Yes.
Feel free to email us directly, Leslie, myself, for additional details and any other follow-up questions that we weren't able to get to in this presentation.
I think we did a good job of manning the Q&A and the chat box. So thank you, Markia, for your assistance. I did, just so you know, Lucas, someone had asked about whether they will get the presentation emailed to them. My response to them was yes, I believe it will go out. Am I correct?
That's right. Yep. It'll go out. It should be today after the presentation is over. We'll send out an updated version of the document.
Okay, wonderful.
That being said, I'm going to go ahead and end the poll and share the results.
Yeah, I think if my memory's right, that's about right where we started the presentation, where we're ending.
Right where we started.
I think it's probably a good indicator of where our level of interest is going into 2024.
Yeah.
Again,
Thank
our
you all for
references
this.
here and contact information here at the end.
All right. Well, thank you, Leslie. Thank you, Sam. Thank you, everyone, for listening in and joining. Like I said, we'll be sending a copy of the presentation out to everyone after the webinar is over. And for those who answered all 3 polling questions, we'll be sending out CPEs in the next couple of weeks. So thanks, everyone. Have a great rest of your Tuesday.
Thank you. Bye-bye.